All right, well, welcome back, everybody. I hope you've all had a chance to check out our sponsors and exhibitors during the extended break. It's now my pleasure to welcome Colleen Schmidt, Plan President of Molina Healthcare of New York, who's going to introduce and moderate the discussion for our next panel, Maintaining Momentum on Payment Reform in the Midst of the Pandemic. Good afternoon and welcome, Colleen.
Thank you, Eric. Appreciate that. And good afternoon. My name is Colleen Schmidt, and it's a pleasure to introduce our next panel and to moderate the discussion that will look at how the move to value-based payment arrangement is proceeding and the challenges that these efforts may face as a result of COVID-19. We're going to start the session with a presentation from Andrea Caballero. Andrea is Program Director at Catalyst for Payment Reform. And Andrea has over 18 years of experience in the healthcare industry. She leads CPR's work in tracking and quantifying progress in payment reform. Prior to joining CPR, Andrea served as Vice President of Enterprise and Health Service Policy for United Health Group. She worked on a range of healthcare policy issues at the state and federal levels and was also a member of Pacific Public Affairs team at the Director of State Government Relations for Western Region. Joining Andrea is Dr. Toyin Ajayi, and Dr. Ajayi is a board certified in family medicine. She is Chief Health Officer at City Block Health, the first tech-driven provider for communities with complex health and social needs, bringing better care to neighborhoods where it's needed most. Prior to City Block, Dr. Ajayi served as Chief Medical Officer of Commonwealth Care Alliance, a national renowned integrated health plan and care delivery system for individuals eligible for both Medicare and Medicaid. And in this role, she led clinical operations, spearheaded care delivery innovations, and oversaw multidisciplinary teams of clinicians, community health workers, and administrators, serving more than 20,000 beneficiaries across Massachusetts. Also with us today is Dr. Lori Zephyrin. Dr. Zephyrin is Vice President of Delivery System Reform from the Commonwealth Fund. Dr. Zephyrin joined Commonwealth in 2019 as President of Healthcare Delivery System Reform, where she leads the vulnerable population portfolio. Prior to joining the Commonwealth Fund from 2009 to 2018, she was the first National Director of Reproductive Health Program at the Department of Veteran Affairs, spearheading the strategic vision and leading system change through the implementation of evidence-based policies and programs to improve the system of women's veterans nationwide. In 2016 and 17, she served as acting assistant deputy under Secretary of Health for Community Care, and later in 17 as acting deputy under Secretary for Health and Community Care. So welcome to all the panelists. I'd like to now turn the session over to Andrea, and so she can get started. We'll get started after Andrea on the panel discussion.
There we go. Just going to share my screen here. Hi, everyone. It's great to be here again. And this is an interesting time to talk about the future of payment reform. So I hope I give us all some food for thought as we think about where we go from here. So as was mentioned, my name is Andrea Caballero, and I am the Program Director at Catalyst for Payment Reform. And if you don't know, Catalyst for Payment Reform is a national 501c3 organization that works with large public and private purchasers. We are working every day to try to improve the functioning of the marketplace, which is no small task. But part of my work is to do that by tracking payment reform at the national and state level, which I will share with you some where we are right now. And in terms of CPR members, we have our members cover over 16 million lives, and they have about approximately $85 billion in annual healthcare spending. So I don't know about where you are. Everyone's probably mostly in New York. I'm in Southern California, but wherever you are, there does seem to be a storm brewing around payment reform. And This is the start of a tornado. I grew up in the Midwest in Wisconsin where tornadoes are common. And you have lots of high winds and they're swirling around. But the one thing about tornadoes is you don't know where they're going to touch down. Unlike hurricanes, where you can tell where they're going to touch and you can predict what's going to happen. I want to carry the tornado analogy throughout this presentation, not because I think payment reform or what's happening is going to wreak havoc on our system, but just to show that there are lots of powerful forces right now that are changing the direction of payment reform and delivery reform. And so the result is a swirl, and a tornado kind of reflects that. So we don't know which way these influencing forces are going to move, but we can try to make some predictions. We like to think about this at CPR in sort of 4 Ps, if you think about what's changing payment reform. So we've got our priors. Where were we prior to today? Then we have the pandemic, and which basically just threw a flaming curveball into the entire delivery system, including what happens to payment reform. And then if you go around to 3 o'clock here, you have politics. That's the 3rd P, and what is the policies that are going to be implemented that could affect payment reform. And then finally, as I mentioned, in terms of who we represent, purchasers, and what will they be doing and how are they going to change it with these wins. So let's talk about the priors. In 2010, CPR asked health plans, and just a handful of health plans, but this is before we started measuring payment reform. We said, how many dollars are flowing through payments that have quality tied to it, that are value oriented or value based? And at that time, it was about 2 to 3%. But when we actually started to measure this with some specific metrics and quantitative analysis, we showed about 11% of dollars were flowing through APMs in 2012. And you can kind of fast forward to 2013, and our most recent data from 2017 shows that we went all the way up to 53%. So between 2012, 2017, a 5-year period of time, you can really see some dramatic increase in the dollars that are flowing through payment reform. Now, we didn't have sufficient data in 2014 or 2015, but I do think it's safe to say that that trajectory was just going up. It was not, we weren't going to take a dip in those years. It was going to continue to go up. So while the overall payment reform trajectory was growing at a very rapid pace, it was much slower for two-sided risk models. And by that, I mean those that have both upside financial benefits as well as downside financial risks. And this is just a slightly different view of the prior slide, where the light blue is showing what is still in fee for service. And so you can see that light blue is decreasing, and we're in 2017. But the teal blue, if you can see it there at the very bottom, those are the payments that show that are payments that take financial risk. And you can see, while we had dramatic changes in payment reform overall, between 2012 and 2017, very little change related to two-sided risk models. So at the very most, only 6% of payments went through contracts that had two-sided risk. So it tells a very different picture when you look at rapid growth in general payment reform, but very little growth in two-sided payment reform. So that's CPR's work. You may know, some of you may know about the Healthcare Payment Learning and Action Network. CPR is the technical subcontractor to the LAN, as we kind of shorthand it. And this is the LAN's framework. And the LAN has been measuring payment reform nationally since 2015. And I've been managing that project, several New York plans, commercial plans, as well as MCOs participate. So thank you for that participation. It helps us get robust representation. And the LAN's framework and categorization is similar to CPR's measurement, except that the LAN doesn't count category 2, which is upside only, but you can think about it as pay for performance. So the land doesn't consider category 2 as counting toward an APM goal. So states are implementing goals, the land has goals, but only categories 3 and 4 count toward the land's goals. So in our last measurement period, we reported this in this time of last year, 2019, and our most recent data is 2018 data. So you can see here, this represents about 77% of the population. So this is in aggregate. That's about 227 million Americans. And in 2018, we had almost 36% of healthcare payments going through alternative payment models. That's categories 3 and 4 under the LAN. And if you think about this in the 5 years that we've been measuring this at the national level, the LAN started at 23%. The LAN also had a goal of 50% by 2018. So the almost 36% falls short of that 50% goal, but we went from 23% to 29% to 34%, and now to almost 36%. So steady progress, and you can see here there's a breakdown by market. Medicare Advantage certainly, I would say, has an advantage in terms of its payment models with its providers. That's why you sort of see it leading the pack, second with traditional Medicare, then commercial, and then Medicaid. I will just say that, again, if you look at all these numbers, most of them are in the upside payment arrangements only. So let's look at the commercial market. These are the LAN's most recent results by commercial. So we saw on the prior slide what that total was. But I want to just focus here on, if you can look at, I guess I can, showing my cursor here, if you can look at the dotted lines. So what's here in the one row of purple and the rest of the green, that's what the LAN considers categories or subcategories that have downside risk. So in the commercial market, for most recent data, we only have about 11% or 10.6% of dollars flowing through payments that have some sort of downside risk associated with it. Again, if you think back to CPR's data, it was only 6% at maximum. I am sort of able to share right now some New York specific data. I don't have slides on this, but I'm happy to sort of share it and can share it offline with folks. But in the commercial market for New York specific, in total, New York had about 51% commercial health plans, about 51% going through alternative payment models. And that is categories 2 through 4. So that's trending on average with the nation, is what we saw at the LAN. But if you look at the what is at risk portion, the commercial market in 2019 had about 21% of its dollars at risk in the commercial market. So that's above average compared to what we're seeing here with the LAN. So it's, these were we have 3 years worth of data in New York now. Some of you might know we measured this back in 2015, and then we do have 2018 and 2019 data. So at least for New York, can kind of compare itself to the national results here. So let's look at the Medicaid results. And again, we're still on the priors as level setting here of the 4 Ps. So this is the LAN national Medicaid results. And again, looking at that dotted box there, those are the LAN categories and subcategories where financial risk, it's two-sided risk. And in the Medicaid market segment, about 8.3% of those dollars were flowing through arrangements that have two-sided risk. In New York specific, this is where the Medicaid really is in New York is kind of outpacing anything I've seen at the national level or even at the state level, where in total, about 80% of dollars in the Medicaid market in New York are flowing through APMs. And so I think as you all in New York have been working on your district programs and other things, this is really showing that those APMs and that movement in the Medicaid market is happening. And then if you think about what is at risk, 53% in the Medicaid market is at risk. and you compare this to the 8.3% here. So clearly the New York results are much more dramatic than you see with the LANS results or even CPRs. So health plans did have a plan in terms of moving providers to two-sided risk. There was a glide path, and so you start with the upside only, the category 2, and shared savings, pay for performance. And then as health plans give more transition to upside and downside risk, they do that as providers have more experience. They're able to work with more data and respond to that data and with time. So that's what was the priors. But then we have the pandemic, and the pandemic came in here, and it really, as I said, it was a curveball, but it was really, is this really a gust of wind toward capitation? Or is this going to be a gust of wind toward consolidation, which could mean something else in terms of payment reform? So, the central problem that if you heard in prior presentations or yet today, the problem in the pandemic is that the providers lack demand for services right now. And so it has exposed providers who are operating either solely or largely on a fee-for-service basis. And you see there, they saw a 60% drop in visit volume, and practices stand to lose about $323 billion in 2020. These aren't New York specific numbers, but it just shows how dramatic, what can happen with the pandemic. So what does this mean to APMs? Again, is this going to be the tension between moving to capitation because providers want some steady revenue, or is it going to move to consolidation because, again, providers might want stable revenue or be under some type of system that has some stability? So I would say the pandemic has softened the ground for movement to capitation, or at least off of some type of fee-for-service model. The Kaiser Family Foundation speculates that these sustained revenue deficits will exacerbate the trend toward consolidation. And in that case, health plans might find it increasingly difficult to negotiate and have the leverage to negotiate if you have more consolidation. And, I think if you look at what private plans are doing, public sector plans, Medicare is doing, I think in acknowledgement of the reduction in utilization, not being able to hit quality targets, you see that plans are giving providers a pass or a buy year in terms of its quality reporting for APMs. One assumes that will resume, but we don't know. So then let's move to politics, which I won't spend a lot of time on, but it's just important to note that, whether you're looking at a Biden administration's proposals on payment reform or current CMS's activity on payment reform, there's modest support, but there really aren't a lot of details. So we can't say too much about how the policies may or may not change. We can talk about how telemedicine policies might change and payment policies might change. But you have, some indication from the Biden administration that there will be some continued movement toward alternative payment models. But we also heard recently from Secretary Verma that of the 55 programs that CMMI put in place, I think maybe only 5 of them actually showed some type of return. And there could be lots of reasons for that. And she does go into lots of explanation about the bars. But, she's hinted at potential mandatory APMs that hold providers at risk in the future, but there just really aren't a lot of details right now. So where the winds of politics take us and policy, we'll have to sort of wait and see. And so then let's think about where the purchasers are. We talked about how there could be a move toward consolidation, and studies have shown time and time again that it's not utilization that's driving healthcare costs and inflation. in the United States, it's price. It's prices. And we have recent data from the 2020 RAND Hospital Transparency Study. And at the end of the day, it revealed that commercial hospital prices showed an average of 247% more than the prices that Medicare pays. This is not New York specific data, but I think when you think about prices and you think about the impact of the pandemic, perhaps moving people towards more consolidation, we as purchasers are concerned about this. So there's lots of things that purchasers are looking at in terms of where are they going to go with payment reform. But I think I will, rather than going through each of these, obviously there's still going to be activity on centers of excellence, steerage within networks, perhaps more reference-based pricing than we've seen, advanced primary care. But I think the most striking data point from the National Alliance's September 2020 survey of purchasers was that 80% of those purchasers said that they support some type of hospital rate regulation. So this is a pretty historic shift toward the openness of government intervention or action on prices. And you don't often hear purchasers talk about the R word or regulation, but this was a pretty significant data point. So it's really hard to draw any conclusions here about what's going to happen with the vortex of all of these winds moving around. But we have a couple of scenarios where we can do some predicting or placing some bets. So on the low probability side, we don't think at this time there will be a massive influx of providers taking on shared risk contracts. There may be some primary care that will move to capitation or some type of hybrid model. But we also think there's low risk that CMMI is going to do away with all of its pilots and be dismantled. This last bullet point was there before November 3rd, but we don't think that the future of payment reform hinges on the election. But then let's look at the medium possibilities in these scenarios. So we do think that some primary care practices will move to capitation. That is a medium probability. And we do think that states are going to be championing some type of change through regulation to address either potential consolidation or pricing. And then on the high probability side, I think it's very probable that you'll have providers that are purchased and acquired by hospital systems, and you will see purchasers who are committed to APMs through other means. But the beacon here is that we know for certain that CPR will continue to track payment reform and monitor all of these winds of change. And I thank you for kind of going through these four P's with me to set up today's discussion. Thank you.
So Andrea, thank you very much for your insight. It was a great presentation. Before we get started on the panel discussion, I just want to remind the audience that at the bottom of your screen, there is a Q&A. So please feel free to get your questions in if you'd like to ask the panelists. So let's start with the first question. I liked your use, Andrea, of the storm brewing. So very, very visual of what's going on. So certainly an understatement of the significant shock to our healthcare system. But how do each of you see payment reform efforts proceeding as a result of this new reality that we're facing? Dr. Zephyrin, I'm going to start with you on that question.
Sure, thank you. And thanks, Andrea. I mean, I think Andrea mentioned, just the financial strain posed by the pandemic on many of these practices. There's a great risk to primary care practices, which really can serve as the foundation of any healthcare system. And there's an increased need to target safety net providers who are experiencing the greatest burden. And so in terms of, as we think through proceeding in the face of this new reality, we need to think about high value models, for example, of care that show the opportunity for providing care during the pandemic and beyond. For example, How do we support telehealth, for example, or for examples around maternity care, how do we support the full complement of birth workers and have payment models that support that? How do we support, for example, out of hospital births? And so out of this pandemic, we're seeing the acceleration and use of models that can be proven to be high value. And there's an opportunity to really ensure those uses during the rest of the pandemic and beyond.
Great, thank you. And Dr. Aji, your thoughts on that?
Sure. I think, there are so many lessons that the pandemic has taught us about the way that our healthcare system is structured and about the really important levers that we need to pull in a time of duress and distress to make sure that that members and communities get the care that they need. And I think one of the really clear lessons that that we need to take from this has been the notion that the fee-for-service healthcare delivery structure, particularly in primary care, is not resilient at times like this. And we see that through the risk of closure of practices. We see that through the dramatic and economic impact that the pandemic has had on many frontline providers, particularly in primary care. And we are just even beginning to start to see the ramifications in terms of really important kind of healthcare utilization that has been missed during the pandemic. And we'll see it when we start to actually measure quality gap closure and we start to see what has happened to the management of chronic conditions in these types of populations. And the converse, when you look at value-based providers, folks who kind of operate in a structure like we do at CityBlock, and also who reflect a significant proportion, a growing proportion of the type of constructs that we see in Medicaid in New York and in other product lines, that we've actually been relatively resilient to the very same experiences, because we have a structure that allows us to invest and to innovate and to pivot. You see massive uptake in telehealth, and that is disproportionate in the types of practices that have the tools and the resources to deploy those mechanisms to make sure that their members and their patients get the care they need, even in the midst of a pandemic. And so I hope that we take a lesson from this that says, let's use this experience to add additional tailwinds to the move towards alternative payment models, to ensure that we're creating resilient structures and infrastructures of care, particularly for your highest risk, most marginalized populations, folks who are likely to have significant long-term sequelae from even a couple of months of deferred care. And to do that, we should be really thinking about the value of value-based care as a core component of that, particularly in primary care and behavioral health.
Great, thank you. I'll switch a little bit. I think we touched a little bit on it and kind of and asked Andrew the question of elements of the value-based, and many of you talked a little bit, but if you can be a little bit more specific in, are there other new payment models that have enabled providers to have arrangements to sort of be able to weather the storm in situations like this? Andrea?
I don't know if I would say that they're new payment models, but they may be new to providers or new to some providers. So I think on as was mentioned, on the primary care side, where there's a reliance, perhaps not intentionally, but a reliance on services and fee-for-service, even on specialty care, this need to have more financial stability and upfront financial stability to be able to weather these storms and be able to, if not provide traditional services, provide other services to their patients that are probably equally as important. I know that CityBlock and others have transitioned to delivering care in a different way, so they can't do that unless you have those payment models in place. So I wouldn't say there are new payment models, except I do think there's a great opportunity here to develop perhaps a new payment model. And it's really more of a hybrid of two, where in primary care, you are able to give primary care physicians and practices some PMPM, some capitation, so they can have that stability. But also there are some services that still should be delivered on a fee-for-service basis. And so some kind of hybrid between the two can give primary care practices some flexibility. So that's not new, but the combination for primary care and specialty care could be new.
Great, great, thank you. Lori, did you want to add to that conversation?
Yeah, I think it's important to add that as we think about these value-based payment arrangements and the possibilities, and we think of the impact of the pandemic, there's really a lot of opportunities there. So for the pandemic, for example, we're seeing increased needs for mental health providers. About a third of Americans are experiencing mental health concerns ranging from anxiety to depression, increasing need for social service referrals. About a third of Americans are experiencing increased social needs due to economic insecurity, ranging from inability to pay rent, to access food for their families. And so I think, just again to what Toyin and Andrea were saying, the ability to support these integrated care models that can address what people need, what families need, is going to be critical. The ability to be innovative around social service referrals and integrate mental health into primary care is important, and value-based payment models really allows more flexibility to do that. Those payers and providers that have had those value-based payment arrangements already in place have been able to, and also have worked with community-based organizations in advance, have been able to flex and adapt in a way that others have not been able to. And I also think it's just really important to highlight that safety net providers are at risk, and that really impacts, the people that are most vulnerable to inequity, people that are most vulnerable to the impacts of the pandemic. And there needs to be resources to be able to target these safety net providers and safety net systems.
Mm-hmm. Very good point. And Toyin, did you want to add to the alternate based arrangement?
No, nothing there. I think this is just a moment of opportunity. If we can stop and just pause a second and reflect that on the wake of this massive tragedy, there's an opportunity to recreate and to build back with momentum and intentionality. And I do think that window is small, and so appreciate the leadership of folks at the Commonwealth Fund, at Catalyst and other places, and starting to put forward policy recommendations that can start to address and reflect and learn from our experiences, because it's going to be very easy to kind of follow the inertia of the moment and allow volume to build back in practices in exactly the same ways as they have before. And I think that there's a real opportunity to think differently about how we're incenting and directing the delivery system in order to make sure that we're learning these lessons.
Mm-hmm. Absolutely. So I like the touch on the mental health and maybe not new, but, kind of looking at some hybrid model and being flexibility in the state that we're in. So really good conversation. Kind of staying with you for a minute as we talk about kind of providers and health plans and reconsidering this whole value-based arrangement and what that looks like. Do we think that some providers are going to drop out of the arrangements? How do we look at your thoughts around that?
I'm happy to take a stab. I think that I think a lot of it will be speculation, and I'm sure there'll be a ton of kind of geographic variation in sort of very specific circumstances for folks. I think what we've seen though from the activities that health plans have taken during this pandemic to try to stabilize access to services, particularly in the finances, particularly of primary care and behavioral health providers, has just shown again what we know from the data, that there's extreme vulnerability amongst those types of providers, particularly safety net providers, that has to be mitigated thoughtfully and deliberately. And so my instinct here is that there's a real appetite for pathways that give folks both the security and the surety of understanding the sort of economic structures that they're going to be functioning within, and very clear achievable targets for what quality and value and success looks like. In my conversations with community providers across the state, I think that there's a real receptivity today in a way that perhaps didn't even quite exist 10 or 12 months ago, when folks had optimized and built and invested really for the chassis that is fee for service. And when the bottom falls out of that a little bit, it creates an opportunity to think about how we do things differently for the future. I do, however, I think, and would love Andrea to speak a little bit more to the flip side, which is that there's going to be meaningful consolidation, and that creates a different path to stability for providers on the front lines that may compete with, entry into alternative payment models and value-based care, and may pose a path of least resistance, which, we know time and time again, and the data compellingly shows, consolidation does not lead to lower prices, nor does it lead to better quality. And so there's a real moment in time here, I think, to create and articulate and partner with providers to create a pathway to value that is at least as attractive to consolidation or to an acquisition as a way to help preserve access and stability for these providers.
Great. Thank you very much. And Andrew, you touched a little bit on your presentation. So is there some cause to concern on providers? Is this really, a time to accelerate and move forward? So if you can touch on that question.
Well, I think Toyin said it, very very well, which is there's going to be geographic variation and there's going to be variation across providers. But I think we will see this tension, and the tension is already there in terms of the desire and the openness, I think, from health plans and providers to work together to change their arrangements so providers can find that stability without having to automatically turn to acquisition or consolidation as their solution. And I think, I no longer work for health plans, but I suspect that health plans want to keep those practices. They want to shore them up. They have been shoring them up with significant financial resources. And as a part of that, they probably want to, they're shoring them up in the short term, and then in the mid to the long term, probably looking at ways that they can be financially stable without having to go through some kind of acquisition as a shortcut, perhaps. And that's not really what I mean, but it could feel like desperation. I need that stability now versus having a glide path. I will say that the LAN has what's called the resiliency framework. I don't know if people are familiar with it, but you can Google it. And it's really a two-sided framework that it gives action items to payers, meaning mainly health plans, not private payers or purchasers, and on the other side, providers, where to be resilient on both sides, payers and providers will enter into some short-term financial stability with the goal of moving toward some type of long-term financial stability in terms of an alternative payment model, either shared risk or capitation and population-based payment. So I think we'll see more of that collaboration through this resiliency framework.
Great. Thank you. Good feedback. Lori, did you want to add to anything to that comment?
I mean, I think the one thing to add is, there, just as there are opportunities in value-based payment arrangements, there are also challenges, and I think Andrea alluded to a little bit in her overview, but really thinking about providing sort of solutions around missed outcome metrics or missed saving targets or struggles with reporting requirements, which can be very challenging for providers during the pandemic. And so how do you, so really ensuring that we're fairly assessing providers who are under VBP arrangements fairly in 2020. And I think the other piece to add is, safety net providers are already less likely to join value-based payment arrangements, right? Because of concerns that they may lose out because of their patients that they see are typically higher risk. And so how do we incentivize safety net providers to join these VBP payment models so that the patients are not penalized because they may present sicker or potentially be more costly?
Well, great. And I'll stay with you for a minute, Lori. So kind of talking a little bit the future, and we sort of talked a little bit about that already, but kind of think through of how should payers, both public and private, under this situation in 2020, really assess those value-based arrangements and beyond?
Yeah, I think that's a great question. Maybe Andrea may have a better answer to that in terms of the how. I do think that there just needs to be an awareness of the risks, particularly to safety net providers and particularly to promoting and inequity. Some of the Commonwealth Fund, we actually had an 18-member task force on payment and delivery system reform that Toyin was a key member of. And, some of the recommendations around, how do you promote adoption of value-based payment models is really, really providing incentives. Are there these glide paths to downside risk? Can you provide startup capital and technical support to practices? Can you align and ensure that there are equity measures and targets so that we can address health inequities as part of these arrangements as well? So I think there are a lot of opportunities there, particularly from a policy perspective.
Mhm. Very good. Thank you. Andrea, do you want to take that question?
Well, I'm not an actuary, so I can't really address, how do we, or how are payers going to assess 2020 and setting the 2020 baseline. I think that is, payers are hard at work right now trying to figure out how do you really set that baseline and what should it look like, because it will be very different. And I will say that, and it's been mentioned, I think the payers and are trying to be very flexible with providers because the utilization is down, them able to hit their screenings and their quality measures. It's just, it's out of their hands. And so I think there is understanding and flexibility and recognition that setting the 2021 baseline will, hopefully not do harm to providers and will be realistic in terms of where should they be starting. Couldn't agree more with the comments that Lori and Toyin have said so far about the providers that are serving at-risk patients and how that and moving them into value-based contracts, it is a different opportunity with different challenges.
Great, very good. We talked a little bit about telehealth and happy to explore that further, but are there other innovations that providers need to consider as they either enter or continue into these value-based contracts? Andrea, I'll start with you, and then Toyin, I'll have you answer that as a follow-up.
So telehealth and telemedicine, I mean, I think they're probably purchasers are ecstatic that what used to be an 7, 8, 9% utilization of telehealth services is now well over 90%. So, I mean, I think it's exciting that telehealth and it's all of its benefits are working for patients, and I think they are working for providers as well. We issued a point of view paper with Mercer and American Benefits Council on needing to take a look at telehealth in a really constructive way as an opportunity to kind of change a new payment model here, because right now, certainly under the emergency circumstances, you have parity in payment between telehealth visits and in-person visits. And while that may have been necessary and may be necessary for the short to mid-term, purchasers have concerns about the cost impact of that long-term. And we want to keep telehealth around. We want to keep people being able to have the access, the convenience, providers like it. So it seems patients really like it, great satisfaction. But if we continue to pay for telemedicine services at the same level of in-person visits, it will not be sustainable. And we're already in somewhat of a cost crisis. And so we have to think about very thoughtfully about how do you adjust telemedicine payments in a value-based arrangement way to create the incentives to continue to provide those services where they're appropriate and pay accordingly, but then also not find ourselves in a bind where we're paying more than you would for bricks and mortar in-person visit.
Very good point. Thank you. Torian, your thoughts on that question?
Yeah, I think that's right. I echo Andrea's points, I think, about telemedicine specifically, and so won't belabor them. I think we have to be super thoughtful about how to incent the right types of flexibilities to allow providers to meet members where they are in whatever ways they need to receive care to preserve access, while being really careful about the potential inflationary impacts of persisting payment parity sort of across the board into perpetuity. And there's lots of ways to do that flexibly. I think we should be thinking about, and I see payers thinking in general about behavioral health very differently from other delivery modalities and from other needs. And I think that's the right thing to do, for the data that Lori has presented, has shared, just about the burden of behavioral health needs, and it being a domain that is so cognitive and relational, and that does not require nearly as much sort of face-to-face or in-person contact potentially to be efficacious, where we have a lot more data around quality and impact and value using multiple modalities, including telemedicine. I think that's a different example, and one worth considering separately as we think about how to invest to ensure that our communities get the type of behavioral health supports that they need. Then I think more broadly to your question, Colleen, about other kind of modalities of care, other skills, capabilities that we need to build into primary care. I think that that we should be thinking again about home-based care delivery and high-intensity clinical supports for people with complex needs. This, of course, is a space that is such an immediate value lever for improving total population health and outcomes when targeted at the most high risk and high need individuals, the people who often don't come into the doctor's office for their appointment, who have needs that far exceed the ability of most practices to solve for in 10 minutes in a doctor's visit or a nurse practitioner's visit. Really understanding that there's tremendous value to that, to getting outside of the office, and incenting providers to do that is important. And then, of course, we can't ignore the importance of integration of social services and social care into primary care, enabling that real full kind of 360-degree view of what each member and each patient needs, and empowering clinicians at the front lines to coordinate and collaborate effectively to close those gaps, as an alternative to ending up solving for those deficits using healthcare, the emergency room largely, which is, as we know, a much more costly and much less efficacious way to do that. So those would be a couple of key parameters. I think the final piece, just that should serve as a reminder to all of us, is a tremendous amount will rest, and throughout the pandemic, frankly, has rested on trusted relationships and truly trusted messengers for very important personal and public health messaging, and the fidelity with which and the responsiveness that we get from communities and from patients directly correlates to health outcomes. And we can project forward in several months' time where, if we're fortunate and if things continue to progress as they have, we, as an example, have a vaccine available. And plans and providers alike will be desperately trying to get their patients to take this vaccine up, because we know that is the most important way, both on an individual basis and from a population basis, that we can start to move towards a return to somewhat normalcy, and where we can start to abrogate and attenuate the risk that this pandemic poses. We also know that at baseline, we're going to be fighting an uphill battle in a lot of communities, particularly your highest risk communities, because there's been such a dearth of clarity and of trust and of communication and partnership with these communities around essential public health and physical health messaging. And so the other piece that providers, we have to really push and incentivize and start to measure more effectively is to what extent are we building real community partnerships? To what extent do the practices and the providers that you are valuing in your networks as health plans really understand the communities that they're serving and have the trust of the communities they're serving? Because that is going to be an increasingly powerful tool to actually achieve the outcomes you're trying to see over time. And how do we partner and support practices to build those relationships if they don't exist already, particularly for the subsegments of the populations that you're serving that are most high risk?
Great points. Lori, would you like to add anything to those comments?
I mean, I think Andrea and Toyin covered it clearly, the social services integration and how can that be supported more with value-based payment models, the mental health integration as well. I think just adding to the social services integration, just the full complement of workers. How do we utilize community health workers and integrate them into the model as well as with community-based organizations. And I also think the equity piece as well, like, how can, we reboot, how can policymakers, for example, or plans reboot, APMs with, specific focus on people served by safety net providers and safety net providers. Can you create APM payment models that exclusively enroll safety net clinicians? Or, is there an opportunity to incorporate the social determinants of health as well? And so I think there's a lot of opportunity around really integrating equity into these value-based payment models that can be done from a policy perspective, big P policy, and also little p policy at the plan level.
Great point. I just want to remind everybody that if they'd like to ask questions of the panelists, that they can hit that Q&A at the bottom of their screen. Andrea, you touched a little bit on kind of the value-based and sort of the at-risk contracts. As we look at some states in New York, certainly one of them, that are considering various aspects of their benefit package and carve out, particularly prescription drug and durable medical equipment, and moving volume reimbursement. Does this create challenges for providers and plans effectively in ensuring that the effective use of these services when we deal with sort of carve outs or carve ins? Can you comment on that? I'll start with you, Torian, and then I'll go to Andrea.
Yeah, so I think that there's, again, this is like, this is going to be super heterogeneous. And I think that there's so many different ways to slice this and so many different ways to approach it. I'm actually very curious actually to hear Andrea's thoughts and perspectives from having talked to plans and getting a sense for how we think about, how we can start to think about being more innovative and creative. And so, I think, again, to reiterate, I think that there's a massive scope on the social side, absolutely, to think through how we build in the evidence and the data, and to support much more creative and much more expansive orientations there. But I think that there's so much that we still don't yet understand as well that we need to learn towards and let the research guide us.
Mm-hmm. Absolutely. Andrea?
I have to say, I don't know New York's policy initiatives specifically right now. But I mean, if you think about the carving out of certain services from these things, certainly carving out prescription drugs, it's a two-sided coin, because if you are a provider, you probably do want that carved out because they're so high cost, and then to be responsible for perhaps compliance, which can be low, and all those kinds of things. It sort of makes sense that you'd want to carve those things out, but at the same time, you're taking out an enormous element of the healthcare delivery of that patient. And so I don't know what the long-term impact is of carving them out or making them, including them, but then holding the provider somewhat harmless from certain aspects of it, so that they're not completely, on the hook for something that they don't have control over. So I think it's hard to say on prescription drugs. I actually haven't heard about carving out durable medical equipment and the impact that could have. Perhaps that, we study more on the commercial side and a little bit on the Medicaid side. I don't know if this is a larger issue in other populations. So I don't think I can comment on that in particular.
Very good. Thank you for your information. So let's switch a little bit in our time allowed to talk about addressing inequalities in healthcare. So, and Torian, I'm going to ask you this question, but as we look at the killings of George Floyd, Breonna Taylor, and Jacob Blake in recent months, has forced kind of a national reckoning on race and racism in America. How can value-based arrangements be structured to help address health disparities and promote a racial equity culture in healthcare?
Yeah, this is a really interesting one. I mean, I think maybe to the first part, I think of my response is to say that that in order to address racial injustice throughout healthcare and our society as a whole, we're going to have to use all the tools and all the levers we have. And so, you know, value-based care may be one, but it certainly won't be the only one. And I think that there are the beginnings of this actually have to start with measurement and with really just understanding and defining the problem. What I think is quite interesting is, you know, when we look at the data, we don't often even have real robust data to help us understand and to measure and describe racial and ethnic disparities as an example, at a plan level or at a provider level. So the first thing you've got to do is if you're thinking about a value-based structure as a tool to advance or to close the gap or to improve or to deliver on an outcome, is you've got to be able to measure it, and you've got to be able to then incent and to tie incentives to performance against the measure. And so one of the things that you know continues to be a starting point here is really looking for support across all levels of the system in gathering data, first party data, patients and community members and plan members about their self-identified race and ethnicity. And that, of course, requires that they trust you and that they trust you're going to use that data in a way that is responsible and that is tied to their health and well-being. And so that becomes a theme that you're hearing me talk about over and over and over again. And then once we have that data, start to actually tie performance measurement to it. And there's a couple of ways that we can think about it. You know, in general, we think about quality measurement either from a withhold perspective or from a performance-based kind of quality bonus structure. Usually it ties to the mean. There's a really interesting question about whether we start to look at distribution and spread as a core metric, as a core part of the metrics that we start to incentivize. And so it will require some creativity. Again, there are some really, really brilliant folks starting to think about how to build out some measurement sets, specifically around racial equity. I think value-based care can be a meaningful lever. We already have infrastructure and language around risk adjustment that at least tries to take into account historical or baseline nuances of a population that may require and justify higher reimbursement in order to achieve the types of outcomes that we're looking for. And so that could be a mechanism to help understand and address the additional lift required to solve for some of these very, very difficult, very intractable and systemic challenges that would lead to racial and ethnic disparities. And then finally, I think that there's a collective need for all of us in the ecosystem to talk about this differently, learn about this differently, measure, and start to really drive accountability.
Very good. I like what you're saying on the data-driven approach on performance. So very good points that the data needs to catch up to being able to measure that. I know we have just a couple minutes left. Lori, I don't know if you would like to have any final comment on this topic of inequities in healthcare, social determinants of health.
Sure. I mean, this is an area that we're diving very deeply in at the Commonwealth Fund. You know, I echo Toyin's points around data, really to be able to understand where we are. It's also important for, you know, health systems and provider systems to confront racism in policies and programs, and also meaningfully engage and partner with the communities that they're serving. I mean, it's really critical to have that true community partnership to really address the structural origins of social determinants of health. I also think from a payment perspective, I think there's an opportunity to incorporate into payment models to be able to shrink disparities. And, you know, how can we incentivize a decrease in racial and ethnic disparities? And I think that's something that we need to think more deeply about. And I think the last thing is around, you know, expanding, diversifying, and training the healthcare workforce. And, you know, that includes from the payer standpoint as well. And so even looking within one's organization and really looking deeply at pay equity and diversity is going to be critical. And it also starts there too. So it's multifaceted. And I think there's a lot of opportunity from a payments perspective and a value-based payments perspective to incentivize addressing racial and ethnic disparities as one of many steps.
Very good. Well, I can't thank enough my panelists. So really great discussion, brought a really insightful look at the current and future of value-based contracting. So thank you so much, and hope everyone stays well. I'm going to turn it over to Eric.
Great. Thanks, Colleen. And again, let me just echo Colleen's comments. Really great to have Lori, Toyin, and Andrea with us today. This has been an exceptional conversation. Andrea, it's always good to have you come back in to help us level set. And Lori and Toyin, you've given us a lot of ideas and things to think about. And we look forward to coming back to you both at some point for future events and further discussions. So with that, just a reminder that we'll be kicking off tomorrow's program at 11 a.m. for our final day. And we have two great panel discussions lined up. The first one is Understanding Single Payer, Lessons from the Canadian Healthcare System. And then our final panel, View from the Marketplace, which will feature local experts on how employers, consumers, and unions are dealing with the health and economic challenges that 2020 have presented to us. In the meantime, we hope you won't miss a minute of tomorrow's sessions. Have a great day. And in the meantime, please continue to stay safe, wear a mask, and we look forward to seeing you all virtually tomorrow.